It's time for another warm-up. Let's get going. What would be seen on microscopic examination of joint aspirate from a patient with gout and then with pseudogout? So for the first, we're going to see the positively birefringent rhomboid-shaped crystals. That's going to indicate your pseudogout. And then the negatively birefringent needle-shaped crystals, that's going to be your regular old gout. Next, where is the Virchow node located? So this is a left supraclavicular lymph node. An enlargement may indicate gastric cancer metastasis. Next, which three cell types present antigens to T cells? So think about your B cells, your dendritic cells, and the macrophages. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about a grab bag of psychiatric issues that tend to affect children, and some lifelong psychiatric diseases that by definition start in childhood, like autism and ADHD. Let's start with talking about autism spectrum disorder, which tends to present very early in childhood, even before the age of 2. Autism spectrum disorder encompasses classic autism and Asperger's syndrome, and all of these old diagnostic terms which are now considered part of a continuum or spectrum. Take a look at the question in your study guide that says, what are the features of autism spectrum disorder? There are two big categories of symptoms. The first is social communication and social interaction deficits. They seem to have very little desire to interact with the people around them. It's like they don't really have any concept that other people have feelings or needs or anything. They often have delayed language skills and difficulty with nonverbal communication, such as eye contact, facial expressions, and social smile. Social smile is where if you smile at someone, they smile back at you, almost reflexively. But these kids aren't wired that way. And the other big category of symptoms is restricted or repetitive patterns of behavior. They may engage in repetitive motor behaviors such as rocking, spinning, hand flipping, ringing, or head banging. They seem to prefer things remaining the same all the time. They like to have routine schedules. They can be very inflexible and can become very agitated when things change. They can have restricted, fixated interests. For example, they may become fascinated with specific objects such as bells or vacuum cleaners, like they're obsessed with any kind of vacuum cleaner. And they can either be hyperreactive or hyporeactive to sensory stimuli. They can be fixated on certain textures or certain smells or sounds, or they can have abnormally negative reactions to certain stimuli, or even indifference to certain sensory stimuli, like they don't even notice extremes of temperature. Next, let's talk about ADHD, Attention Deficit Hyperactivity Disorder. While autism spectrum disorder often begins to manifest itself very early in childhood, ADHD is typically diagnosed a little later, often around elementary school age, but symptoms must be present before the age of 12. It's more common in boys than in girls, and it's not uncommon for symptoms to continue into adulthood. This isn't necessarily something you grow out of, although the prominent symptoms may change over time. The symptoms can include attention deficit, decreased attention span, and or hyperactivity, increased energy and impulsivity. So you can have attention deficit or hyperactivity or both. And these symptoms must be present in multiple settings, both school and home, and at soccer practice or Cub Scouts or whatever, multiple settings. Then for the treatment, take a look at your study guide. The mainstay of treatment is stimulants, which cause release of catecholamine in the synaptic cleft. You might think that stimulants would not be a good idea for ADHD, where the kid's already hyper and busy, but for some reason, they're often very effective. There's methylphenidate and dexmethylphenidate, which block the reuptake of dopamine and norepinephrine. There's mixed amphetamines like Adderall and dextroamphetamine, both of which increase presynaptic release of norepinephrine. Mixed amphetamine is a mixture of both the levo and dextro isomers. And there's a drug called atomoxetine, which is not a stimulant, but it works by inhibiting norepinephrine reuptake. So the end result is increased norepinephrine in the synaptic cleft. This is usually a second-line drug. And you can also see alpha-2 agonists like clonidine and guanfacine use second line, even though they reduce norepinephrine output in the brain. The exact mechanism of why this works in ADHD is not well understood. Another disorder that tends to have onset in those early school-age years is separation anxiety disorder, which is an anxiety disorder in which the fear of separation from their parents or from home, or even a blanket or favorite stuffed animal, causes impaired functioning. All children display a certain amount of separation anxiety at some point, but in separation anxiety disorder, it's severe enough to cause impairment in functioning. They may refuse to go to school or fake a stomach ache or some other illness in order to avoid separation from the caregiver. Let's also discuss hair pulling disorder, which is sometimes called trichotillomania. This is found in your study guide. Hair pulling disorder is a compulsion to pull hair out of the scalp, which is related to obsessive compulsive disorder. It's more common in young girls. You might find broken hairs of varying length. This is different than alopecia areata, which is a smooth bald spot with well-defined borders. Here's an image of a 6 or 7-year-old boy with a rather large bald spot, and at first you might mistake this for alopecia areata, but we know this was caused by hair pulling disorder because his parents reported seeing him pulling on his hair. He says, "It just feels good to do it." There's stress or tension inside, and pulling the hair kind of relieves that tension. So it's a self-comfort mechanism, kind of like sucking the thumb. We treat this by educating the patient, reminding him or her to stop pulling out hair. You can use cognitive behavioral therapy, trying to get the patient to be mindful of what he or she is doing, or having the patient verbalize the underlying stress or tension in order to confront it in a more constructive way. And then, if non-pharmacologic intervention fails, we sometimes use fluoxetine, which is an SSRI, or clomipramine, which is a tricyclic. Let's briefly discuss Tourette syndrome. Tourette syndrome is defined by the presence of stereotyped movements called tics. They have both vocal tics and motor tics. We tend to think of Tourette syndrome as someone who just blurts out profanity uncontrollably, but that only occurs in about 40% of cases. We call that coprolalia, which is a great word. Copro means feces and lalia means speech. So coprolalia is literally potty mouth. Great word. And sometimes they have motor tics that are obscene gestures, which is called copropraxia. But the motor tics are more commonly things like involuntary blinking or facial grimacing. Tourette syndrome is usually diagnosed around age 10 or 11, and the tics have to have lasted for at least 1 year. It usually resolves by 18, but it may persist into adulthood. The treatment can include behavioral therapy to help patients learn to hide the tics, or alpha-2 agonists like clonidine, or anti-dopamine drugs like flufenazine and pimozide, which are both neuroleptics. Next, I want to talk about 2 disorders in the impulse control family: conduct disorder and oppositional defiant disorder. Conduct disorder is a persistent pattern of behaviors that violate social norms and the rights of others. Aggressive behavior, violence, threatening or bullying, destruction of property, deceitfulness, and theft. The disregard for the rights of others is a big part of it. Setting things on fire, cruelty to animals, that sort of thing. It's as if they don't care about what we, society, says is wrong. So if they give you a patient that's torturing animals and is disregarding the rights of others, think about conduct disorder. The only major difference between conduct disorder and antisocial personality disorder is the age of the patient. Antisocial personality disorder can't be diagnosed until the age of 18, although those individuals do start out with conduct disorder as teenagers. So before 18, we call it conduct disorder. Then, oppositional defiant disorder is a bit less drastic. With oppositional defiant disorder, ODD, there's a persistent pattern of disobeying authority and hostile behavior, but no serious violations of social norms and no disregard for the rights of others. They aren't as physically aggressive toward animals or toward other people, and they don't generally get into destruction of property. So you definitely need to be able to distinguish between ODD and conduct disorder. Conduct disorder is the more serious one. An oppositional defiant kid might talk back to his teacher, but the conduct disorder kid is the one trying to blow up the teacher's car or microwave the cat. Let's talk about child abuse. This isn't exactly a psychiatry topic, but it can certainly lead to psychiatric problems in children and adults. Child abuse can include physical abuse, sexual abuse, even emotional abuse, with or without neglect. You have to have a high index of suspicion for child abuse because parents don't come in saying, "I've abused my son." Look for inconsistent history, stories that don't make sense. For example, my 1-month-old rolled off the bed. Oh, really? Because 1-month-olds don't roll over. Physical exam. Look at the overall child. Is she attached to her parents? Clean? Fed? Look at the skin. Cigarette burns or any sort of burn in the shape of something that might suggest abuse. What about bruises? Bruises on the shins are normal for active, playful kids, but bruises on young infants that aren't mobile yet are very suspicious. There's a saying, kids that don't cruise shouldn't be bruised. Multiple fractures at various phases of healing suggest possible abuse. You can also look at the location of fractures. Look for rib fractures from squeezing the child or spiral fractures from twisting the child's arms. On head CT, you might see unexplained subdural hematomas, new or old, from either blunt trauma or shaking. And shaking a baby can also lead to retinal detachment. And what do you do when you suspect child abuse? You report it to Child Protective Services. Anyone can report suspected child abuse, and you don't need proof, just suspicion. Physicians are legally obligated to report suspected child abuse. This might show up as an ethics question where they describe some injuries that suggest abuse and ask what steps must be taken. One of those next steps would be reporting the suspected abuse. What about sexual abuse? Physical abuse and sexual abuse may coexist in the same child or within the same family. Sexual abusers are usually males that are known to the victim. On physical exam, look for evidence of anal or genital trauma, which often is not present on exam, but you still look for it. Any sexually transmitted infection in a child is strongly suggestive of sexual abuse. You might also suspect sexual abuse in a child that exhibits sexual knowledge or behavior beyond what they should know at their age. Any inappropriate play with toys, dolls, or other children could be a big red flag. And then there's child neglect, which is the most common form of child maltreatment, but could be the hardest to prove. Neglect means the failure to provide for a child's basic needs, and it can come in many forms. Failure to provide adequate food, resulting in malnutrition, failure to provide shelter, failure to supervise the child, leading to unnecessary injuries. It could be medical neglect, failure to care for the child's illnesses or injuries, and even failure to send the child to school could be considered neglect. These children may present with malnutrition, failure to thrive, poor hygiene, and impaired social or emotional development. And just like child abuse, child neglect needs to be reported to CPS. Children who are neglected may exhibit poor socialization skills, poor language skills, inability to trust others, and even poor feeding and weight loss and failure to thrive. They may have poor muscle tone. It's kind of the infant version of depression. In fact, this is classified as reactive attachment disorder, especially in children over 9 months of age, which is where the child becomes emotionally withdrawn and emotionally unresponsive to other, and the child exhibits sadness and fearfulness and irritability, even when there's nothing going on to make him sad or fearful. Now you're ready for the end of session quiz. First question. What name is given a chronic compulsive hair pulling common in young girls? The current terminology is hair pulling disorder. Next, what stimulant medications are commonly used in the treatment of ADHD? Methylphenidate, dexmethylphenidate, mixed amphetamine, dextroamphetamine. The others, like atomoxetine and clonidine, are non-stimulants. Next, which childhood psychiatric disorder matches each of the following statements? Impairments in social interactions, communications, and play, plus repetitive behaviors equals autism spectrum disorder. Ignoring the basic rights of others equals conduct disorder. Characterized by hostility, annoyance, vindictiveness, disobedience, and resentfulness equals oppositional defiant disorder. Multiple motor and vocal tics equals Tourette syndrome. Impulsive and inattentive, ADHD. 7-year-old that avoids going to school to stay home with parent, that's separation anxiety disorder. Then there's one rapid fire fact. The most common medication for ADHD is probably methylphenidate, Ritalin. That's it for now. See you next time.